Hi, I'm Nora Barlas, and I'm going to present effective treatment of macrophage activation syndrome linked to systemic lupus erythematosus using interleukin-1 inhibitor. So for background, before getting into the case, macrophage activation syndrome, or MAS, is a rare hyperinflammatory condition with a high mortality rate of 8 to 22%. It is a secondary hemophagocytic lymphohistiocytosis, and it involves activation and proliferation of T lymphocytes and macrophages, and it causes a cytokine storm. So it can be triggered by infections and malignancy and can occur as a complication of autoimmune disease such as lupus. And the prevalence in lupus is between 1 to 9%. It can also be associated with other conditions like systemic juvenile idiopathic arthritis, Kawasaki disease, and adult onset Still's disease. You can use the HLH 2004 criteria to aid in the diagnosis of MAS, and you can see that on Table 1 for reference. Interleukin 18 and CXCL9 are also elevated in MAS, and they can help with the diagnosis. Treatment is typically high-dose IV pulse steroids and other immunosuppressants. Diagnosing MAS in patients with lupus is challenging, but is also associated with high mortality. So our patient was a 19-year-old female who presented to the hospital with altered mental status. She has a past medical history of lupus, diagnosed 3 years ago, and lupus nephritis, which was diagnosed 3 weeks ago. She was on hydroxychloroquine 200 twice daily, prednisone 60, and mycophenolate 500 BID at home. So when she presented with the altered mental status, MRI head, CT head, lumbar puncture, and blood cultures were all normal. Labs revealed anemia, neutropenia, leukopenia, low C3, and elevated dsDNA. We diagnosed her with an active lupus flare and initiated her on standard lupus treatment with steroids. Despite the treatment, she had persistent high-grade fevers throughout the hospitalization, which you can see on Figure 1. And through the labs, we suspected macrophage activation syndrome. She had elevated ferritin, triglycerides, her ASTs were elevated, her fibrogen was low, and we also ordered an interleukin-2 receptor alpha, which was elevated. So you can see her lab values on Table 2. Table 2 shows her labs on admission, after we gave her the IV Solu-Medrol, and after we gave her the interleukin-1 antagonist anakinra. So you can see that. So we initially initiated her on IV steroids, pulse IV steroids for 3 days, and her fevers did improve within 24 hours of the pulse steroids. However, after transitioning her to oral prednisone, her fevers recurred and her ferritin increased, her CRPs increased, and her transaminases increased. We got a bone marrow biopsy which showed hypocellular marrow with multilineage hematopoiesis and maturation. We repeated the infectious workup due to the fever, and the TTE was negative for endocarditis. We decided to initiate the interleukin-1 inhibitor anakinra on day 8. And then she had improving ferritin, CRP, liver function, and her mental status improved. So she was discharged on the anakinra. On follow-up 6 weeks later, her mental status was completely at baseline. So in conclusion, macrophage activation syndrome is a severe complication in lupus patients. This case highlights the challenges of managing macrophage activation syndrome in patients with lupus. Despite initial improvement with high-dose IV steroids, the patient's condition necessitated further intervention with the use of an interleukin-1 receptor antagonist, anakinra. The successful use of anakinra led to a rapid and sustained clinical improvement and emphasizes its role as a critical therapeutic option in MAS cases. This case underscores the importance of recognizing MAS in lupus patients, maintaining a high index of suspicion, and considering anakinra as a potential treatment to improve outcomes. Thank you so much.